taking time out to join us for our glaucoma webinar part 1, brought to you by the Caribbean College of Family Physicians. Our theme for today is Clarity in Sight, Advancing Eye Health and Glaucoma Management. So we begin tonight's proceedings with a prayer by our wonderful Dr. Anna Brown Morgan, wonderful family physician and our executive member. Go ahead, Dr. Morgan.
Dear Father, we give you praise for this educational meeting and for our purpose in imparting cutting-edge medical knowledge to all in attendance this evening. We know that when we gather together, you always have a divine agenda. We know that when we have done our best, the results will be multiplied in greater measure. Thank you for your provision of our speakers today for this webinar on ophthalmology. Thank you for our audience of interested physicians and for our support staff of able workers who are joined together in this moment. Please take what our speakers have prepared on behalf of the Caribbean College of Family Physicians this evening on eye health and glaucoma management and multiply the good of their presentations as only you can. We give you thanks and praises throughout this meeting, dear Lord. Grant us peace today, dear Father. Keep us all physically safe and guard our hearts and minds. By the guiding light, for all, be that guiding light as we set out to accomplish and to learn as much as possible in this group meeting this evening. In Jesus' name, we pray. Amen.
Amen. Thank you so much, Dr. Brown Morgan. We'll now move on to the welcome by our very capable president, Dr. Seni Onanuju. Go ahead, Dr. Seni.
Good evening, colleagues, distinguished speakers, moderators, and esteemed guests. It is my great pleasure to welcome you to this special 2-day virtual CME seminar hosted by the Caribbean College of Family Physicians Jamaican Chapter in recognition of Glaucoma Awareness Month. Our theme, Clarity in Sight, Advancing Eye Health and Glaucoma Management, underscores the importance of early detection, effective treatment, and multidisciplinary collaboration in preserving vision and preventing blindness. Over the next 2 days, we will benefit from the expertise of our distinguished presenters who will share critical updates on the latest advances in glaucoma diagnosis, management, and patient-centered care. Their knowledge and insights will undoubtedly enhance our clinical practice and improve outcomes for those affected by this condition. I extend my heartfelt gratitude to our special presenters for their time and dedication, and to our moderators whose guidance will ensure engaging and thought-provoking discussions. A sincere thank you to our secretarial staff and IT team who work tirelessly behind the scene to make this event possible. To our attendees, physicians, nurses, and allied health professionals, your presence here reflects a shared commitment to continuous learning and improving patient care. We also acknowledge and appreciate the contributions of the Accreditation and Planning Committee and the Caribbean College of Family Physicians Jamaican chapter members who continue to support and drive medical education initiatives. A special commendation to Dr. Maynard McIntosh for his invaluable efforts in the planning and organization of this seminar. Also importantly, we extend our deepest gratitude to Indos, our event sponsor. Your support plays a crucial role in making this educational opportunity possible, and we truly appreciate your commitment to advancing healthcare. As we embark on this learning journey together, I encourage you to engage actively, ask questions, and apply these insights in your practice. May this seminar empower us all in our mission to enhance eye health and prevent blindness. On behalf of the college, I invite you to sit back and enjoy the presentations as I look forward to an enlightening and productive session. Thank you, and God's richest blessings to us all.
Thank you, Dr. Ananuju. So our first presenter is Dr. Maynard McIntosh. Dr. McIntosh will be joined by Dr. Renee Bedrow, who is a final year resident in the DM for ophthalmology, who has a keen interest in glaucoma. Dr. McIntosh is no stranger to us. He's a graduate of the University of the West Indies, and he has garnered his wide range of surgical skills through collaborative surgical programs conducted by faculties from Europe, the United Kingdom, the United States, the Dominican Republic, South, and even South Africa. He has developed unique approaches to things like a small incision phaco cataract surgery, minimally invasive glaucoma procedures, and he has several modalities of non-surgical management for diabetic retinopathy. Being a philanthropist, Dr. McIntosh, through his company, Eyelight Optical, has over the years conducted island-wide vision screening in schools and institutions, providing free and sponsored eyewear as well as surgical care to many children and adults. I present to you Dr. Maynard McIntosh and Dr. Renee Bedrow. Thank you.
Good evening, colleagues.
Hi, good afternoon. Good night, everyone.
So we are taking on the topic, glaucoma silent thief of sight, and then we're doing it a different style. You know, we're kind of doing the media thing where we co-host this talk, and we'll jump right into it, going through some of the basic sciences as a background for understanding exactly how the process of glaucoma works and why it is really a spectrum of eye diseases. It's a neurodegenerative condition that actually is not only limited to situations where there's an increase in intraocular pressure, but there are certainly many instances, and certainly I would say most instances, where the intraocular pressure is normal, but the process happens and is discovered only when a detailed examination is done, which is why it's a silent thief of sight.
So, in understanding the pathophysiology of glaucoma, it's imperative that we understand and discuss the pathophys of what is normal and how aqueous is produced. Now, within the eye, you have what's called the ciliary body, and in the ciliary body, you have what's called ciliary processes. And ciliary processes are responsible for the production of aqueous humor. And there are different methods that you can produce aqueous humor. You have the active transport method, you have passive diffusion, and you have ultrafiltration. Now, with regard to aqueous humor, there is the diffusion of certain ions inside and outside of the ciliary processes. And when we begin to discuss the mechanisms of how the drugs operate, this will bring the understanding of the pathophysiology will bring everything a little bit clearer and a little bit more to the forefront. Now, after aqueous is produced, the aqueous then would need to be drained. Now, as I said before, the ciliary process produces the aqueous humor. The aqueous humor now enters into the posterior chamber and then goes through the pupil and into the anterior chamber. What are the pathways that it can exit? It can exit either through the conventional pathway, which is the pathway that's located on your left, or it can enter through the unconventional pathway, also known as uveoscleral pathway or outflow. With the conventional pathway, the aqueous humor passes through the trabecular meshwork, goes into Schlemm's canals, goes into the collector channels, and goes into the episcleral veins. However, in the uveoscleral pathway or the unconventional pathway, the aqueous humor would move from the anterior chamber into the ciliary body, suprachoroidal space, venous circulation, and then it would go into through the venous circulation of the ciliary body, sclera, and orbit. Right. Now, as we've moved past the drainage of aqueous, how do we now understand the pathophysiology of glaucoma? There is a mechanical theory of glaucoma where there is an elevation in the intraocular pressure that causes the damage to the optic nerve head, as well as would cause some damage to what's called the retinal nerve fiber layer. It would cause atrophy. There will be widening of the optic cup, and there will be thinning of the axons, and the support matrix that holds everything together will be damaged by glaucoma. Now, with that damage, you would have an impairing the function of the nerves, of the axons. You'd have an impairment you'd also have damage to the retinal ganglion cell layer. And unfortunately, or fortunately, when the retinal ganglion cell layer and the microglia, when they respond to an acute increase in IOP, they respond by releasing what's called pro-inflammatory mediators such as TNF-alpha, IL-6, NO, nitric oxide, as well as complement. And if this continues beyond a certain point, what you end up with now is retinal ganglion cell apoptosis. Now, this slide is just to go through the basics of the anatomy. All right, so we have in picture A, we have the retinal nerve fiber layer, RNFL, the choroid as well. Now, I just want us to pay attention to this. I'm not sure if you can see my pointer, but I want you to pay attention to this pink layer, retinal nerve fiber layer. This is a part that gets really damaged during glaucoma. If with an acute increase in the IOP, we see that, with the inflammatory mediators that are released, the pressure that ensues. But when we have a chronic increase in the intraocular pressures, we now have what's called remodeling. And in this remodeling, you'd have thinning of the cup, the optic cup, you'd have widening of it. You would also have thinning or atrophy of the area. And as this continues and the damage increases, we would have a progression of our glaucoma. Apoptosis of the retinal ganglion cell layer has been found in glaucoma to be something that's of very of particular importance, and it is the main reason for damage that occurs in the optic nerve head. Now, when you have apoptosis, you'd have this cell death of the retinal ganglion cells. It can explain to us, there's certain types of glaucoma, and we're going to get a little bit into it a little bit later on, but the apoptosis that occurs in glaucoma will explain certain types of glaucoma besides those that happen when the intraocular pressure is elevated. You can have what's called normal tension glaucoma, and you can have also what's called low tension glaucoma. Now, just to reiterate, we spoke about first the mechanical pathophysiology with relation to glaucoma, increasing intraocular pressure and the damage of the retinal ganglion cell layer. However, on the other side as well, you have what's called apoptosis. And with this apoptosis, we can now explain why in certain types of glaucoma, it happens even in spite of having a normal or a low intraocular pressure. And normal intraocular pressure ranges from 10 to 21. Now, another pathophysiology for the death of the apoptosis of the retinal ganglion cell is that it starts to be gene regulated. So glaucoma really is a mixture of different causes and different risk factors. And with this risk, with these different causes, it's very important that we understand that the different mechanisms that can exist to possibly cause this disease as we try to understand it.
Okay, so now that we have gotten a sense of where we're at in terms of the retinal anatomy and the physiology of aqueous production and drainage, we can look now at how we detect early. And I'm addressing now my colleagues as family physicians. It's very important to take a history, family history, drug history, ocular history. Patient may have had surgery before. Do a review of systems, of course, because we will discuss later about diabetes, and there are other conditions or systemic conditions or chronic illnesses that can align themselves with glaucoma as a part of a syndrome. If the patient has had complaining of pain, halos, or scotomas, or which are black, dark spots or hazel spots in the vision, that means it's late. Because usually glaucoma in its early stage is asymptomatic. It's asymptomatic. Fundoscopy with your direct fundoscope is important. I mean, it's since COVID, persons are not willing to get too close to patients, but in the days that we were, then if you ask a patient to look at the opposite ear, meaning if you're examining the right eye, the patient look at your left ear and you go close enough and dial in some pluses in your ophthalmoscope, you will see the optic nerve quite clearly and be able to estimate the size of the cup in relation to the disc as a fraction or decimal. Note any afferent pupillary defect, because usually if there's an afferent pupillary defect, that nerve is gone. Practice to ballot the eye, ballot the normal eye with 2 fingers, just as you ballot a cyst. And when you get a sense of what the normal eye balloted feels like, start with your own. And you will be able to tell if there is too much tension in an eye. That's a good sign, but if you don't have a tonometer. And there is a flashlight, which I'll show you a slide of that I'll do after this test that you can do, shining the flashlight at about 60 degrees from the side. If you're temporal, for example, which is from the side of the ear and the lights. Let me just jump to that slide. I hope is it? I took the place. But something do I have to? Okay, no. Is it coming up? That's the image. No, not. Okay, so until we get there, but what it really is it's related to the Van Herrick's. The Van Herrick's we do at the slit lamp with a slit. And if the slit shines on the cornea and then on the iris, and the space between the slit and the iris is about, the same as the size of the slit, then the angle is open. If there is no space, then the angle is closed. If you shine a flashlight from the side, you get the light reflected on the same side as where the light is coming from, then the angle is narrow. If you get the light projected on the opposite side of the pupil, meaning from shining from temporal, for example, you see it on the nasal side, then that means the chamber is deep enough and the angle is actually open and not closed. They meant to go with a case of an open angle glaucoma. We're trying to get through a technical difficulty here. Just give us a moment. But let me speak while we wait on Okay, so let me speak on retinal photo. And that topic will come up when we deal with telemedicine, teleophthalmology. I am encouraging doctors to get patients in the habit of doing an annual photo screen. I know that there was a diabetic retinopathy screening program that was conducted in the last few years, but there are still cameras around. We have a camera in office here, and several doctors and optometrists as well have cameras. Encourage your patients to get the photos sent to you via email. And these photos are very, very useful, not only in looking at optic nerve, but for those doctors. We all look after patients with diabetes and hypertension and dyslipidemias and so on. And you can get a very good sense of what is happening with the diabetes by looking at those photos annually, and you can also detect progression. So photo screen, I think, and telemedicine will become very, very important. It's important presently, and it will get more and more important as technology increases. Also, as soon as we all can sign up on some kind of EMR, we have an EMR system here. We've had it for many years. When we are on EMRs that can connect with each other, then we can share from doctor to doctor some of these images that can form a part of your patient record and help in the management of or the co-management of the patients along with us. Okay, so the slide that you're seeing, we have to revert to another set of slides.
So we need to share again.
Yeah, share this slide. Are you seeing it now?
Yes, healthy vision, early glaucoma, advanced, moderate.
Right. So that, for example, when you do a history for a patient, the patient tells you, okay, they're seeing everything fine, versus in advanced glaucoma, moderate glaucoma, where they think they see like they're looking through a tunnel or a narrow channel, and they're, for example, if they drive, they'll tell you that they're not seeing when the bikeman comes up on the left or right, and they keep getting into accidents and so on. That's a sign that they do have significant scotomas. I want to advance. Okay, so this is a demonstration of the flashlight test. So you notice that the glow is on the patient's nasal side, and the light is actually being shone from the temporal side. You give a pointer. Yes, from the temporal side there, and it projects onto the nasal side. So it means that that angle is open. Next slide. We in the office will do a gonioscopy, of course, to detect, and not enough gonioscopies are being done. We can see clearly the Schwalbe's line, the pigmented trab, and the scleral spur and so on. And we know that that angle is open because you see all the way down to the root of the ciliary body. So that's a grade 4 angle. That's very, very important in determining whether it's an open angle or closed angle glaucoma situation. Thanks. And that, if you see that, walk into your office, of course, hazy cornea, painful eye, acutely loss of vision, fixed mid-dilated pupil, and signs of inflammation. You see the KPs, you see those brown spots on the inner layer of the cornea. We're talking about an acute narrow angle, could be chronic narrow angle attack, and that is a medical emergency. To save the vision, a lot of gymnastics have to happen, and it has to happen pretty fast, including laser injections and possible early surgery to alleviate the situation. And these can lead to permanent blindness, not only just from the optic nerve standpoint, because it will take a while for the optic nerve to die out of that condition, but you will get venous occlusion or arterial occlusion, and that is what will take the vision out. Okay, next. Okay, and so the risk factors mainly we look at heredity, which I would say more than half, up to 70% of patients who have glaucoma will report that there's some relative, maybe 2 generations back or even present, and siblings will have the condition as well. Being over 60 make you 1.6 times more likely to have glaucoma. 6 times more likely to have glaucoma when you're over 60 years old. The African descent, Asians, Hispanics are all prone for various reasons. I think with Asians, it's really a narrow angle situation because the structure of the eye tends to be different and they tend to have a lot of myopia. Trauma and medication, steroids in particular, and for those persons treating asthmatics, if there is use of over, I think it's over 20 doses for the day, they can develop glaucoma because the steroid accumulates systemically and can cause a steroid response, causing increased intraocular pressure. Comorbidities related to the eyes, like high myopia, high hypermetropia, which causes narrow or compromised angles. Thin corneas, because thin corneas, even with normal intraocular pressure, can mean that they can get glaucoma because the functional pressure is actually higher. And ocular hypertension is a risk factor. In ocular hypertension, the pressure is high, but the nerve looks normal. But that can also put you at risk for glaucoma. Okay, so as I said before, if you're 60, you're very likely to have it. Older Hispanics and Asians, Japanese tend to develop normal tension glaucoma. For some reason, I guess they're more prone to apoptosis next. Okay, and as I mentioned before, asthmatics, but not only asthmatics. If you're treating collagen vascular diseases with steroids or for dermatological use, those persons are actually at risk for glaucoma and for cataract formation because cataracts can come from steroid use. In rheumatology and immunology, some of those medications, yes, can lead to glaucoma through the accumulation of steroid levels. And of course, not only blunt trauma, but penetrating trauma and chemical injury. Chemical injury is kind of weird because you not only get inflammation and increased intraocular pressure, but the cellular body can actually be shocked. I have seen patients develop low eye pressure or hypotonia and eventual phthisis from caustic injuries. So in early detection, just to recap, annual exam with your ophthalmologist. Don't hesitate to refer, especially if there's a family history. And we do routine fundoscopy, annual photo screen, as I said before. And we're going to look now at OCTs and perimetry. This just demonstrates how the photograph can really, really help you. And on the right, I'm not sure if you can see it from here, but where my mouse is, this area is of importance because it is the nerve fiber layers here that you watch. And in good photos, we use a confocal biomicroscope technology for our photos. So you can zoom it to wherever and you can actually see nerve fibers and see where they drop out. That's early detection of glaucoma. Because when you can see nerve fibers missing, even before you see the cupping, or even before you see significant field changes, then you'll have gotten it early. So that's very important. The photography. And the OCT, that's a normal OCT, optical coherence tomography. This gives you cross-sectional appreciation of the retinal layers, and it also will tell you what the cup to disc side is. It's kind of hazy, but this is a cup nerve here, and the cup is this space in the middle. And so the printout will give you all of that. But from a layman's point of view, you tell the patients if everything is green in the little pie charts, then they're good. If in this next slide, you'll see the colors start changing, and in the pie charts, you see some pink areas, then you know that the yellow is borderline and the pink is too thin, and that represents glaucoma. And we see it here in the nerve fiber layer loss represented in the pink segments in the inferior temporal and superior temporal on both sides. And that is how the OCT helps you to detect glaucoma, and it gives you a read-off also of the cup-to-disc ratio. Visual fields usually walk hand in hand. You can almost map a good visual field over an OCT. The OCT looks at structural loss. The visual field looks at functional loss. That's a normal visual field with normal blind spots. But this slide shows you what a scotoma would look like. In this case, that's okay on the left, but on the right, you have a field with a lot of dark areas there, which represent central scotomas. And of course, there are some arc-shaped scotomas on the outskirts, but that is severe glaucoma with central field loss. Okay, and so the management strategies are usually targeted to the physiology. And so, as Dr. Badro mentioned earlier, for example, you would have carbonic anhydrous inhibitors, which is a pretty good drug because it gives you maybe 20 to 30% a drop in intraocular pressure, up to 40% sometimes. We target carbonic anhydrase, which is the enzyme that mediates the hydration of the carbonate in the ciliary, the non-pigmented epithelium of ciliary body, and that cuts down the production of aqueous. That's Diamox, and in the form of drops, there are many commercial brands available, but pretty much it's still the same acetazolamide. The alpha adrenergics also target lowering of the aqueous production and the increase in outflow. The new kid on the block, of course, rho kinase inhibitors, which also increases the scleral, the uvascleral outflow, as well as the trabecular meshwork resistance. So it relaxes the trabecular meshwork, so there's better outflow, and it also relaxes the walls of the scleral vessels. But these all come with their side effects. Prostaglandin analogs increases the uvascleral outflow, but it also creates quite a bit of inflammation because, as we know, prostaglandin is an inflammatory mediator. And so the eye looks like it's going through an inflammation, which is why it's used at night. Beta blockers reduce the production of aqueous, but it must be used with caution. Certainly don't use it in asthmatics or persons prone to bronchospasm. Myotics, like your pilocarpine, increases the outflow as well by widening the angle, but again, has its side effects in causing brow ache and certain spasm feelings in the eye. And so patients may complain. It also induces a myopia. Now, laser.
1 minute left in the presentation. 1 minute left.
Yeah, man, no problem. So we have laser modalities, which will be covered later by our presenters, and the surgical options will also be presented. So that last slide pretty much summarizes what I spoke about with the different meds and how they target. One thing they've not zoned in on is how to target the apoptosis in normal tension glaucoma. That remains a mystery. Thank you. Somebody's muted.
So our next presenter is Dr. Kay Liu, who is a resident physician at the Duke University School of Medicine. He attended medical school at the University of Hawaii, and he completed his undergraduate studies in biomedical engineering at the University of Miami. Dr. Liu has gone on 3 global ophthalmology mission trips to Haiti and Mexico. And tonight he'll be talking to us about pediatric glaucoma, early detection and management strategies, understanding congenital and juvenile glaucoma. Over to you, Dr. Liu.
Hi, everyone. I hope you can see my screen and my mouse here. I'm excited to give this talk, and thank you for the introduction and the opportunity to speak to all of you, members of the Caribbean College of Family Physicians. The title of my presentation is Pediatric Glaucoma, Early Detection and Management Strategies, and we'll jump right in. I unfortunately have no financial disclosures. And as for an outline, I have a clinical case introduction and a multiple choice question that we can think about. We'll discuss and review a basic eye anatomy and mechanism of glaucoma development, although we might gloss over that a bit as Dr. McIntosh gave an incredible introduction and overview of that. We'll talk about different types and causes of pediatric glaucoma, classic clinical findings on the history and physical exam, how to measure intraocular pressures in children, the importance of initial management and referral, and we'll conclude with the clinical case conclusion and a multiple choice question review and some take-home points. So a lot to go over, but we'll take it one step at a time. We'll start off with a baby in your clinic, and here is a picture of that. He is a 2-week-old male just here for a routine appointment. And then parents say that maybe one eye is slightly larger than the other. And they're also saying that the patient is tearing a lot, seems very sensitive to light, and doesn't want to open his eyes much. And they're asking you, hey, doctor, is there anything that we should worry about? And so here's the multiple choice question I'd like you to think about. A would be, would you reassure the family that these symptoms are transient and can be normal for infants? Or B, would you say, hey, we should prescribe some antibiotic eye drops. I think I know what this is. Would you C, refer the patient to ophthalmology within 1 week? Or D, refer the patient to ophthalmology within 2 months? So we'll give you a second to think about it, and then we'll come back to it at the end of the presentation. I also have one other multiple choice question here. It is, what is the most serious long-term complication of untreated congenital glaucoma? Is it A, myopia or nearsightedness? Is it B, complete blindness? Is it C, strabismus or misalignment of the eyes? Or D, corneal ulcer, which is an infection on the front surface of the eye? I'll give you a second here to jot down your answer. And again, we'll return to this at the end of the presentation. So as Dr. McIntosh mentioned earlier, and I'll briefly talk about it here, the aqueous humor is produced in the ciliary body pictured here, and it flows past the lens and the iris, the gap here, through the pupil, and then out through the trabecular meshwork, and goes out of the eye. And as Dr. McIntosh has mentioned, while this is a simplistic way to think about it, glaucoma is essentially optic nerve damage with characteristic visual field defects that is a lot of times associated with elevated eye pressure. And a way to think about that that I tell my patients is you can think about it as a bathtub or a kitchen sink where there's fluid that's being built here or produced here and flowing through. And then the drain, if the drain is messed up, then there's going to be an overflow of water or fluid in the eye, increasing that pressure. And that's the general thought process. In terms of primary congenital glaucoma, some theories include there may be a membrane that's covering the drainage area. There could be developmental issues when the baby is forming in the womb of this angle, and that can cause backup of fluid in the eye. So in terms of classifying glaucoma, the timing of when it presents is helpful. And so congenital glaucoma is present at birth. Infantile glaucoma occurs before age 3. And juvenile glaucoma is this big range between ages 5 through 35 years of age. And you know, different textbooks and Articles have slightly different numbers, but this is the general rule of thumb to think about. And how common is it? Congenital glaucoma, about 1 in 10,000 births. Juvenile glaucoma, about 1 in 50,000. And do know that there's an increased risk of glaucoma in infants or children who've gone under surgery for congenital cataracts. And we'll talk about some of the other risk factors related to glaucoma. We'll talk about it here. So primary. So another way to think about pediatric glaucoma is whether it's primary or secondary. And primary essentially means that there's no identifiable cause. There are some studies that have said that there may be specific gene mutations that have been associated in about 10% of cases. But in most, by and large, primary means that there's no identifiable cause. Secondary glaucoma means that glaucoma developed as a result of different things, including aphakia, which is the lack of a lens, aniridia, which is the lack of the iris or the colored part of the eye. As Dr. McIntosh mentioned, trauma, and then previous eye surgery, like cataract surgery, and can be associated with genetic syndromes and much more. So many different reasons why one could develop pediatric glaucoma. And how do these patients present? These young patients, these congenital ones, I'd like you to remember these 3 symptoms because they're very important. Number 1 is tearing. So they'll make a lot of tears and they'll also be very sensitive to light. And this last one here is blepharospasm, is twitching or involuntary muscle movement of the eyelids. And that's the classic triad of congenital glaucoma. For juvenile glaucoma, these folks are typically asymptomatic. They don't really see or realize that something is wrong. They may have some blurred vision. They may have ocular pain if the eye pressure is very high, or at late stages, they may have peripheral vision loss. Some exam findings would include, especially for congenital glaucoma, this term called buphthalmos. Buph is Greek word for ox, and buphthalmos just means that the eyes are much, much bigger than they should be. So you can see here in this picture, this eye, or both of these eyes, and this child from South Sudan, Dr. Williams, one of my mentors, passed along this image to me. It's a photo taken by he and his group. But you can see in both of these photos that the eyes are larger than one would expect. And if you were to measure them, the definition in most literature is that it's greater than 12 millimeters before the patient is 1 year old. A lot of times when the pressure is high, the cornea can decompensate and become cloudy as well. And so you can see here this whitish hue, the cornea is cloudy there. And if you were to press or touch on the eye, you can feel that it's pretty firm. And patients may suffer from decreased vision as well as loss of peripheral vision. What are other things you should think about when you're suspecting glaucoma? You got to make sure that these other things are not going on. And so in terms of the symptom of epiphora or tearing, maybe it's the nasolacrimal duct and the drainage system between the eye going through the nose. Maybe that drainage system is blocked. If it's blocked, then there are going to be increase of tears within the eye. Well, maybe it's a eye redness, whether it's a viral cause, a bacteria, or just plain allergies. Maybe that's the reason why the patient is tearing a lot. So you have to rule that out. Or maybe there's a injury or a defect on the front part of the cornea. Maybe that's why the patient is symptomatic and tearing. That can also occur. Photophobia or light sensitivity. Maybe there is inflammation of the iris, the colored part of the eye. Maybe the patient recently suffered some sort of traumatic event and caused inflammation or led to inflammation in the eye, which can also manifest as light sensitive. And lastly, the cornea can be cloudy for a variety of other reasons besides glaucoma, and these would include birth trauma, chemical injury, an infection on the cornea, or congenital reasons for cloudiness of the cornea. And what would you do if you are concerned about glaucoma? Well, the main thing, especially in congenital cases, it's important to refer to an ophthalmologist within 1 week. The reason being is that elevated pressures in these young children can lead to irreversible optic nerve damage, vision loss, and also amblyopia, which is the inability for the brain to fully develop the visual system. And once this occurs, then there's no way going back. And so it's important to counsel the family, and it's better to be safe than sorry. So it's better to refer if you're suspecting glaucoma in a very young patient. And just a little aside here, how do we measure the eye pressure in children? I mentioned, we could technically touch it, touch the eye and just feel it, but there are more accurate ways. There are tonometers here. This is the eye care. This is the first generation, and this is the more updated one. But these basically allow you to get pretty close to the patient's face and get eye pressures. In adults, we have ones that would that are shown here, or we can do it at the slit lamp. But as you can imagine, getting this close to a child or having them climb into the slit lamp is quite cumbersome at times, and it might be quite difficult. So in general, it would be the eye care, or you could consider using this in conjunction when an ophthalmologist takes the patient to the operating room and does an exam under anesthesia. So essentially when the baby is asleep. And the normal range of the eye pressure is between 10 to 12 millimeters of mercury in infants. In contrast, in adults, it's anywhere between 10 to 22. And so infants, their pressures should be a lot lower than adults, or on the lower range of normal for adults. And how do we treat glaucoma? As Dr. McIntosh alluded to earlier and discussed, the essential goal, the one thing that we can change is to lower the eye pressure. And this really reduces the risk of progression in glaucoma. And different ways that we can do it: topical eye drops, oral medications, lasers, and of course, surgery. However, and these options, exist for adults. I think in general, lasers and surgery would be the mainstay treatment for congenital and juvenile glaucoma. Partly it's the anatomy, and also in terms of compliance, it's much more difficult to get patients to use eye drops and take oral medications when they're much younger, but it's also because of the anatomy. But medical management can be a temporizing measure while awaiting surgery. It would maybe help to clear some of the corneal clouding, which is a direct impact of very high pressure in the eye. And one oral medication that can be given is oral carbonic anhydrase inhibitors like acetazolamide. And that would mainly decrease the aqueous humor production with associated side effects. So just be careful of that. And topical eye drops are not usually as effective. And I do want to caution and make you aware that brimonidine, it's this purple color top. This is actually contraindicated in children under the age of 2 years because of systemic sedative effects. And so folks have had coma and even had died from brimonidine. So certainly do not give this to any children under 2. And of course, talk to your friendly ophthalmologist or speak to an eye doctor before prescribing this or any other eye-related eye drops. What kind of surgery can we do? One surgery is called goniotomy, and this is going into the eye and opening up this drainage system or drainage area of the eye. Another way to do it is accessing it from just the outside part of the eye and going in and splitting this part open. And these two are essentially the first line or the first approach when treating congenital glaucoma. If that doesn't work, then a flap can be made on the outside of the eye. Or if that doesn't work, then maybe a tube shunt, which allows makes another tunnel to again let the aqueous drain externally out of the eye. And lastly, one other option would be to laser the ciliary body. And remember that the ciliary body here is what produces the aqueous flow. And so another way to think about it is these 4 surgeries would increase the drainage system of the eye, and then this laser would reduce the production of the aqueous within the eye, both in hopes to reduce the pressure within the eye. Will the child become blind? And so visual outcomes can vary. It depends on when the diagnosis occurred, what type of glaucoma, was it primary, or if it's secondary, what was the etiology or the cause of it, and also whether any sequelae of the glaucoma led to amblyopia or a failure of the brain to develop the neural optical visual pathway and all that, that can certainly make an impact. In general, though, the surgery is quite successful with over greater than 80 to 90% have good control of the eye pressure. And so that's really important in reducing the risk of progression in glaucoma. And we've seen this picture before earlier this evening already, in terms of how glaucoma can slowly take away the peripheral vision and leave you with just the center part here. So back to our case of the baby in our clinic, we noticed that indeed that both eyes are enlarged, and the left one is even larger than the right. Mild, and we do even just see from using our naked eye without a microscope that, yeah, the cornea is a little cloudy. And if we were to touch it, it is firm. And so we are suspecting congenital glaucoma, and the plan was to, and the patient was referred to an ophthalmologist within a week. The eye pressure we had checked was also, so when they went to the ophthalmologist, the eye pressure was 30 on the right and 35 on the left. And if you remember, in infants, it should be about 10 to 12. So this is more than 3 times as high. The cup to disc ratio was 0.5. I didn't quite mention this, but in the earlier presentation, we had talked about the cup to disc. In kids, it should be less than 0.3. And as glaucoma progresses, this cup to disc increases. And so 0.5 here is abnormal. And so the diagnosis of congenital glaucoma is made. And so as we talked about, there are many surgical things to, surgery is the mainstay treatment. And so the patient undergoes a goniotomy and is currently doing well. And so to complete this multiple choice question, the answer here would be refer the patient to ophthalmology within a week because you're concerned about congenital glaucoma, and that warrants an urgent referral. And what is the most serious long-term complication of untreated congenital glaucoma? That would be complete blindness, because again, glaucoma leads to irreversible optic nerve damage. And so if it's not treated, folks will go blind. So summary, glaucoma is characterized by damage to the optic nerve with corresponding visual field defects and is associated with high eye pressure in most cases. And important for us to remember that congenital glaucoma, these 3 symptoms, epiphora or tearing of the eye, photophobia, light sensitivity, and blepharospasm or twitching of the eyelids is very classic for congenital glaucoma. Exam findings would include buphthalmos or enlargement of the eye. The eye is very firm to touch, and there may be corneal clouding as well. An urgent referral to ophthalmology when you are suspecting glaucoma. And surgery is the mainstay treatment for pediatric glaucoma to reduce the eye pressure. And irreversible vision loss can be prevented. And here are my references. And I'd like to thank Dr. Gupta, one of the glaucoma specialists at Duke, as well as Dr. Lloyd Williams for their help and mentorship and review of this presentation. Thank you.
Thank you so much, Dr. Lee. That was an excellent presentation. Our next presenter is Dr. Fletcher. He is an ophthalmologist with a passion for teaching. He's even taught ceramics at his undergraduate university, the Washington University in St. Louis. He went to his hometown, which is in Pittsburgh, at the University of Pittsburgh, to complete medical school, where he implemented an ophthalmology lecture series designed to mirror the organ system curriculum in place to make a rarely taught subspecialty more accessible and relevant to medical students. It was the chief resident system at Washington University that drew him back for residency. This is a system where the chief resident is a separate postgraduate year dedicated to supervising the inpatient consult service and trauma service with abundant opportunities to teach. He went on to complete a year as chief, which has motivated an interest to remain in academic medicine. He's currently completing a fellowship in glaucoma at Duke University. He'll be speaking to us today about advances in medical and surgical treatments for glaucoma, exploring the latest therapies, including minimally invasive glaucoma surgery. I hand over to you, Dr. Fletcher.
Hi, everyone. I hope you can see my screen all right here. Thank you for the introduction. My name is Nathaniel Bletcher, and I'll get going on this presentation that we have to review some advances in alternative treatments for glaucoma, aside from what folks might be more traditionally used to. So hopefully this will advance for me. Yep, perfect. So I also have a couple of pre-test questions here. We'll go over all these and then we'll come back to them afterwards in the post-test time. So the first question would be, what is a reasonable first-line treatment in place of topical drops for glaucoma? And then 3 options there of different lasers. And then the second question here is, what do patients rank as their most important outcome for microinvasive glaucoma surgery, or MIGS? And then another several answers here: reduce their number of eye drops, continue to drive a car, have control over intraocular pressure, or improve eye surface symptoms. So what's the most important outcome? All right, we've actually had a couple good reviews already on some of the basics of glaucoma function, so I won't spend a ton of time here. Just needless to say, this is a picture that I ripped off of from my first aid book that we used to study for our first step of medical board licensing here in the US. And I remember looking at this photo and thinking, thank God that I'm not going into ophthalmology, because I don't want to memorize all of this. But then I did end up going into ophthalmology, so this is all relevant. But we've already reviewed some of this, so I won't spend a ton of time here. Just as a little bit of history before we get into modern treatments. Where did we start with glaucoma treatments? Medications have been around for quite a while. Pilocarpine, that Dr. McIntosh went over a little bit as for its function, has been around for a very long time, since the 1870s. But one of our, quote, traditional glaucoma drops that came after that didn't come out for another 100 years, timolol. And then one of our standby oral medications that we use from time to time has been around from the 50s. As far as surgeries, the first surgeries, all of these were aimed at lowering eye pressure, essentially through increasing drainage through the eye. And one of the first surgical treatments for that would be just literally putting a hole in the front part of the eye, corneal puncture. And then after that is our kind of quote unquote traditional glaucoma surgery that we think of, trabeculectomy. And that's been around since the 60s. But interestingly enough, and thanks to Dr. Liu for going over this a little bit for goniotomy, goniotomy is something that we think about as a quote unquote MIGS, but that's been around for almost 100 years now. So MIGS are not necessarily new. They are something that's been a hot topic, though, because there's a lot of innovation within that field. And so speaking of innovation, this is somewhat where the landscape stands nowadays. And you can see just the number of additional things that we have here. And I think some of this has already been broadly overviewed as well, so I won't spend a ton of time here as well. But you can just see how many options there are now between many different kinds of medications, many different types of lasers that we can apply, and many different surgeries as well. But I think the most important thing to try to bring this back to is how does this apply in your clinics when you're seeing folks in your family medicine clinics? Why are these new advances in glaucoma care relevant? And I think probably the main one to think about here is that a lot of patients have family members who have gone through glaucoma treatment. And they might remember how arduous that could have been. A family member taking many different drops or having gone through a traditional trabeculectomy surgery and maybe having a poor experience with it. And just the frequency of care that was required. And we'll touch on a couple of things that might show that that doesn't necessarily need to be the case. And then a second thing is, I know a lot of times people are being referred to ophthalmology for cataract surgery. And it's a good time that we might be able to combine care for glaucoma and have an opportunity to do some glaucoma care at the same time. So when somebody might be complaining about blurred vision and they might be ready for cataract surgery, this is a good opportunity for glaucoma care as well. And then finally, kind of circling back to the idea of medication use and that being a concern for patients, even if there's a patient who struggles in other areas of their medication adherence in general medicine, that might not be a barrier to receiving some of these other possible care options for glaucoma, and they might still be able to have good care. And on that note, this is not necessarily a MIGS, and it's also not super duper new in the field of glaucoma. But SLT is one of our lasers, selective laser trabeculoplasty. And this is a light that's applied to the natural drainage system, the trabecular meshwork of the eye. And because of that light application, it enhances flow through that natural drainage system. So this is something that is done in our office. It takes only a couple of minutes to do. It does take some training and skill to be able to do. But for the patient, it's painless and it can help with eye pressure. Particularly, this has become somewhat of a sea change in the world of glaucoma, because we traditionally had thought that, medications is the first thing that we do. And then maybe somebody gets a laser, and then maybe somebody gets surgery. And it was this very down the path pipeline way of thinking. And we always would start with medication for people who were earlier on in glaucoma care. However, SLT is a reasonable first-line treatment, and that has come largely from this light trial that showed that it was as effective as a medicine, or in some cases it had benefits over medicine. In particular, things that make SLT a great first-line therapy is a single treatment can last 1 to 3 years. So one couple minute in-office procedure might be enough to control glaucoma for years. If that does wear off over time, it can be repeated if it was initially effective. And they're actually doing more studies now to show possibly even if it wasn't initially effective, that it might be effective on repeating. And then nearly 70% of patients who got SLT were at their goal pressure without any additional eye drops. So these are, it's a large majority of patients who don't need eye drops after being treated. And so a single in-office treatment, again, can really control their glaucoma. The people who used the laser rather than drops reported better quality of life indexes. And it's more cost efficient than having to continue to buy drops to use. So all of these reasons really make SLT a great first-line therapy. And so where is this going? So that we can talk about modern advances a little bit more. There's a new technology that's been emerging called direct SLT. And this has several advantages, the main one being that it doesn't need a lens to be able to apply it to the trabecular meshwork. Instead, this is applied transsclerally. So completely externally, a patient just puts their chin in this device, and an automated procedure applies it with a click of a button. So there's no learning curve to performing the SLT. It's been reported to be basically exactly as effective. And because it would make it so fast and easy to do, there's some potential that this could widen access to SLT being applied widely as a first-line treatment for many patients. And then on to somewhat of the title of this talk here, MIGS, or often called minimally invasive, but technically micro-invasive glaucoma surgery. As far as why they're important, like I mentioned before, they can be combined with cataract surgery. They're not a replacement for traditional surgery, though. They are not as effective as our large tubes and trabs, but they are a reasonable option depending on how severe the glaucoma is. So for earlier cases or only needing to have mild improvement of pressures, people who aren't on maximal treatment, these are reasonable steps in therapy. And they can be done standalone as well. They don't have to be done with cataract surgery. So as far as what defines a MIGS, I think this has been slightly touched on as well, but basically they are small. They're small surgeries that don't require a lot of recovery. They're safe, and they don't carry the same risks for vision loss or need for revision as our other surgeries that we do in glaucoma. So there's a lot less barrier to entry to do these, and that makes them a lot more widely applicable. So this is a title that I made for another MIGS talk a long time ago. There are a lot of MIGS, and I'll get some more on the screen here in just a second. But it sometimes does feel like Mad Libs when we're doing this, because there are so many different ones that we could put in place of different things. But to widely break them into categories, there are stenting procedures that are done, and that is creating, using a piece of hardware that stays inside the eye to increase flow. There are stripping procedures that are done, and these are things that are opening up the trabecular meshwork to increase flow. And then kind of as a third category, and technically I would include it within MIGS because it fits that bill of being minimally invasive and quick recovery, would be types of lasers that are done intraocularly. So these are not external lasers. This is endocyclophotocoagulation, so applying heat directly to the ciliary body from inside the eye. I would count that as a MIGS as well. A couple things here, the CyPass, that's dead now because it got recalled, but there are always new things coming out that might replace that. A lot of these are proprietary or sometimes expensive devices though, and they don't necessarily need to be used to achieve these same things. This is a photo of something called a bent angle needle gonioscopy. And all this is a 25 gauge needle that's been bent, and you can see how similar that is to that Cahook dual blade or KDB device. And it can do the same thing, achieving gonioscopy of stripping that trabecular meshwork. And then I thought it'd be useful to share a couple of videos here to just show you what these look like in practice. These are courtesy of Dr. Herndon, and this is the eye stent that's being applied into the trabecular meshwork here. So we're visualizing the trabecular meshwork directly with a gonio prism, and then you can see these stents being inserted into that trabecular meshwork to allow outflow through it. And you can see that little spot of blood at the stent, and that's reflux through the episcleral veins. That tells us that we're in the right spot, that the stent has been applied to where it needs to be to have access to the outflow system. And then this is a goniotomy. Again, this is that Cahook dual blade, that kind of proprietary device, but this could be easily achieved again with a bent 25 gauge needle. And you can see that this is again, the trabecular meshwork. that is being physically stripped out. And you'll see a strip of that trabecular meshwork after he's finished passing there. And that white that you then see behind that is the sclera. And so we've directly opened into that Schlemm's canal for the outflow there. So what does this all mean for all these different devices? And what's the difference between all of them? Because like I said, there can be kind of feels like Mad Libs at some point. Basically, larger stents or things that strip more of the trabecular meshwork are more effective. So that bigger Hydra stent is better than an iStent in general. There's not a ton of long-term studies to show how effective these are over a long period of time. That larger Hydra stent probably has the best data. And they do show that they reduce the need for bigger surgeries over time, but likely they do probably wear off over time as well. You know, these MIGS are not permanent cures for glaucoma in any way. They're a step along the road because glaucoma tends to get worse over time. And this is often how I describe it to patients. You know, it's sort of like a roadmap. At different points, we'll need different treatments. We might be able to start with that laser. You might need a drop as things get worse, and then you might need a MIGS surgery with your cataract surgery, and then you might need to go on to a larger surgery later, depending on how severe the glaucoma is as it continues to develop and how much we can control it along the way. So this is getting towards one of our questions here. But what was important to patients for their MIGS procedures? The number one thing was control of their intraocular pressure, which is a little interesting because the pressure is just a number. It's like saying somebody really wanted to have good blood pressure or good heart rate rather than they wanted to feel good walking around. But you know, when we're doing glaucoma, we're very fixated on this pressure number, and we tend to give that pathology to our patients sometimes by being over fixated on the number. You know, the pressure really is just important for whether or not they're having progression of their glaucoma. But this mainly shows that people are looking to have a way to feel like they're in control of their pressure. So I think it kind of gets down to patients feeling on things over time for their glaucoma care as well. And then just another quick note on future horizons. There are other exciting things in the line as far as devices. And these are becoming actually available for use in the United States here and across the world. You know, there's ways to do medicine without having to do drops all the time. These are little implantable devices that have a tiny amount of medicine in them that elute over the course of several years. This one in particular is called iDose, have travoprost in it. It's one of our prostaglandin analogs. Basically, it's a drug-eluting stent, except instead of in the heart, this one's in the eye. And it's been shown to be non-inferior to a topical drop, and in 20% of the cases, maybe 2 drops. But we don't have any real long-term studies on how that affects glaucoma in the long run. But these are very attractive because there's sometimes patients who can't take drops, even more so than just quote unquote non-compliance, but they might have physical limitations that make it hard for them to manually apply a drop, or they might have surface reactions to drops themselves. A lot of our drops really do cause some side effects. And so having an option that avoids that, whether it's a laser or a drug-eluting stent like this, is very attractive. So just to circle back to our test questions from the beginning, what do patients rank as the most important outcome for their microinvasive glaucoma surgery or MIGS? It's actually having control of that eye pressure rather than anything else. So this is something that's very important to patients. And what is a reasonable first-line treatment in place of topical eye drops for glaucoma? Of these lasers, it's the SLT, the selective laser trabeculoplasty. So I just want to say a special thanks to Dr. Herndon, who made some contributions to this talk for me, and thank you for your time and attention.
Thank you so much, Dr. Bletcher, for that very detailed presentation. We will have our question and answer segment at the very end of this seminar. Our next presenter is from one of our sponsors, Indus Life Science. So I'll ask Mr. Hutchinson, I believe, to do so now. Thank you so much.
Hey, Shamari, are you talking? Because we're not hearing you. Shamari? Dr. Bukal, can you hear me?
Yes, I can hear you, son. I don't know what's happening
No
with
problem.
this stuff.
Okay. Again, thanks everybody for joining. Just want to ensure that we're hearing Shamari. Shamari, I don't know if maybe you have a device that's plugged in that's taking up the mic, or what you can do is in Zoom where the microphone is, there's a little arrow right to the top right of it. If you click on that, you can see if you can switch your microphone to another one that's probably available to you. Not hearing you yet, but while we do that, I want to thank all 228, wow, huge number, on a Wednesday evening for joining the CCFP. Kudos and congrats to Dr. Onanuju and Lynn and all of the team at CCFP for their wonderful marketing and mobilization and getting these wonderful international and local experts to have the talk. We thank Indus for coming on as a sponsor. And we are seeing the presentation, but not hearing Shamari. I'm not sure why. Let us try once more with Shamari. Shamari, what you could also do, where you click on that mic, you should see where it says test speaker and microphone. You could probably run a test for me, just to ensure you can pick up your audio and pick up the speaker. That might identify any areas that we need to improve on for your audio. All right, Shamari, not hearing you still. What I'm gonna ask you to do is perhaps do a quick test of your audio and speaker. And Dr. Bukal, I'm gonna ask if you could just slot Indus as our wonderful sponsor for this evening in maybe in another maybe after the next
Hello?
presentation.
Oh,
Yes,
Oh, there you
so
go, Shamari, you came back. But I'm hearing myself echoing now. Are you hearing me?
yes, I'm hearing you.
Oh, there you go. We are
So
hearing you. If you go ahead and share your screen, we could go ahead.
okay, so I'm not hearing from my computer, so I'll be using my phone.
No
Okay, so
problem.
I'm
Thank you.
Shamari. I'm from Indus Life Science. So I'm just giving a brief overview of our ophthalmology line of products. So Our first product is the Timodus. So that's our timolol maleate solution. It's a beta blocking agent, and it's indicated for ocular hypertension, chronic open angle glaucoma, and pediatric glaucoma. And this one, it's available in all pharmacies in Jamaica. It's very useful in reducing intraocular pressure and to reduce the production of aqueous humor. Our next product, this is the dorzolamide. So ours is called Dozodus, which is also used for open angle glaucoma and ocular hypertension. It's a carbonic anhydrase inhibitor, and it is used for, it's currently available in all pharmacies, and it's currently under $1,000 for it in the pharmacies, 1,000 Jamaican dollars. The next product is the brimonidine called Brimdus. This one, it's a combination of the brimonidine and tartarate. And how this one works is for dual mechanism to reduce aqueous humor production and increase uvascleral outflow. This one is under 1,000 Jamaican dollars, and it's available in our pharmacies also by prescription. The next product is the Dozodus T, which is a combination of dorzolamide along with timolol. And this one, it is covered by the NHF, so it's available in our public hospital and pharmacies. And it's used to safely and effectively lower intraocular pressure. And another class of product that we carry is for the cell dust, which is our artificial tears. It is used for the dry eyes. We have two concentration. We have the 1% and the 0.5% concentration of the cell dust. And this is Carmelose solution. We also carry anti-infective. So we have the Ciprodus, which is ciprofloxacin, along with Tobradus, which is tobramycin, and we also have a combination of tobramycin and dexamethasone, which is called the Tobradus D. And just to remind you of our other products, this is the new gel. This is our antacid. This one is a third generation antacid, which contains alginic acid. It helps to relieve gas and prevent GERD. So this one, it's sugar-free. It has a balanced composition of magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, and dimethicone. Safe in children and pregnant mothers, and it is also safe in the diabetics. And an extension to that is the new gel O, which is our antacid. This one, it helps with relieving stomach pain, and it has this unique ingredient called oxytocin in it to help relieve stomach pain for gastritis patient. This one, though, is not recommended for children and adults. And this one, it's not recommended for children and adults and children and pregnant mothers. And our supplement, the AminoPet, which contain all essential amino acids. This one has zinc along with all the vitamins that are needed on a daily basis. And this is the end of my presentation. Sorry about the technical difficulties. I'll leave my contact in the chat, so if you are located in Jamaica and you need sample, you can contact me.
Thank you, Mr. Hutchinson. We will now commence our fourth presentation, and we're back to Dr. Maynard McIntosh who will this time speak with us on diabetic eye disease and glaucoma, a dual threat, the impact of diabetes on glaucoma progression and management. Back to you, Dr. McIntosh.
Okay, thank you. So I won't let the other catch me this time, the timing. So let's jump right into the presentation. So I'll present patient Mr. X as our subject for discussion. I have no disclosures, unfortunately. Okay, so Mr. X is a 54-year-old male accountant with a history of 12-year history of diabetes. He's on Mgment, BID, 50 milligrams citalopram. You know what that is. And for his hypertension, he's on amlodipine. He has glaucoma and he is on Azarga, which is a combination of acetazolamide and timolol, both eyes twice daily. And he was seen 4 months prior to his current presentation. And then his intraocular pressures were 15 and 19, which, as Dr. Badrol mentioned, is within the 10 to 21 range for adults, normal range. His vision was 20/25 in the right and about 20/40 minus in the left. Now currently presents with pain and blurred vision in the left eye, and this is of recent rapid onset. So the questions to answer at the end, and the questions are actually related to Mr. X, is these questions are one, what is the cause of Mr. X's vision dilemma? Is this diabetes? Is it worsening of his glaucoma? Is this new vessels in his drainage angle, or is it all of the above? Question number two, how do we treat his emergency? Do we remove the eye immediately, or do we give him some glycerol to drink? Because glycerol can lower eye pressures when taking at least 1 ounce, maybe 3 times a day with some lime. That's a quick go-to. Do we administer oral Diamox, IV monitor, do an avastin injection, and follow up with some lasers? Or do we drain the excess aqueous in the office? So we'll return to those questions at the end of the presentation. So Mr. X presented with visual acuity of 20/40 in his left eye. So this is what his fundus would have looked like. We see a little macular edema, some hard exudates hovering in the temporal macula there. This is okay, and the vessels, the caliber is okay, and the perfusion is okay. You can see there from the color, though, that orange color, that something might be looming, but all in all, that accounts for his 20/40 vision when seen a few years ago. Now, in this presentation, if we could get to see the fundus, we'd be seeing something like this, where a lot of new vessels are sprouting on the disc, as indicated by the arrow there. And if you follow my cursor, my mouse, you will see tons of new vessels, superior and inferior to the disc, and some membranes start forming, we call it neovascular membrane. And the neovascularization is sprouting even into the macula itself, with a lot of dot and dot hemorrhages and increasing the amount of exudates associated. So this is quite a flare up that would have happened over that short period of time. And at the slit lamp, or this is even a blow up of what his anterior chamber would look like. We're looking at his iris, and we see the iris looks pretty inflamed. Lots of new vessels creeping all over the iris, and there's even some bowing of the iris, almost like there's a shallowing of the anterior chamber, looking as if we're entering the stage of an angle closure. So this is quite a flurry of activity. There is what's called some synechia also, which is a mark of inflammation um, just about here, because this is the lens of the eye. So there's stickiness of the iris to the lens. So that is a picture of what neovascularization or neovascular glaucoma can be like in a diabetic, because it all starts with the diabetes. So continuing with Mr. X, along with the photos I showed you before with what the iris and the fundus looks like, the blood pressure is 165/105, his GMR is 16.9, visual acuity now 20/30 in the right, and in the left eye that we viewed the photos of, the visual acuity is 2200. And the intraocular pressures are right, 19, left 48 millimeters, but he was still using his Azargo when he came in. So of course, we're left with that now. He presents with all of this. Where do we go from here? Because this is a patient with glaucoma, and the glaucoma is now a complex glaucoma because he has primary open-angle glaucoma, diabetes, and this is now complicated by two other good friends of glaucoma, cousins if you would like to call them, neovascular glaucoma and narrow angle glaucoma. So let's look back at the approach I decided to take was to see if we could see parallels between diabetes and glaucoma. And this is now glaucoma from the point of view of the optic neuropathy, because glaucoma is actually an optic neuropathy. It's the matter of increased intraocular pressure is just one of the mechanisms by which you can trigger this neuropathy, but a lot of it can happen even without the help of raised intraocular pressure. So we look first at the fact that both have microangiopathy as a part of the pathophysiology. So in diabetes, of course, we all know that the small blood vessels are badly affected. There is apoptosis of the vascular endothelium due to reduce in the adhesiveness. And this dropout or the apoptosis manifests itself in dropout of the endothelial cells, and therefore you get, certainly in the eye, we are very privileged as ophthalmologists to be able to witness all of this that may happen in the brain or the kidney, where we look in the eye and we can see the leaking of the plasma into the retinal tissue and also blood through these spaces in the vascular endothelium. And so this is usually a mirror of what happens, or reflective of what happens in other organs in the body. And so diabetic retinopathy walks hand in hand with the nephropathy, for example. And so we use that as a marker to know when patients are likely to be up for dialysis and so on, and when the practitioner and family doctor should really pay close attention to the renal function when there's severe retinopathy. The ocular blood flow is important around the optic nerve, and studies have shown that it is interruption in this ocular blood flow around the optic nerve that is part of the pathophysiology of normal tension glaucoma. And so just as you get retinal dot clot hemorrhages in diabetes, you can get disc hemorrhages in glaucoma to indicate its severity. And of course, as I said before, the apoptosis that you see in diabetes is also part responsible for the compromising of the vasculature around the optic disc and its the optic nerve and its supporting structures. And a lot of this happens through the oxidative stress, because oxidative stress is can affect all tissues. And it brings about an impairment in the autoregulation of the environment around the optic nerve. And so, you know, in both, you see it in diabetes, you see it in normal tension and low tension glaucoma. And both have genetic and immune components. You know, diabetes, it's a family thing, and so is glaucoma, kind of thing. And there is some immune deficient or defect in both. And both have an inflammatory component because, matter of fact, treating diabetic retinopathy, there is a place for injectable drugs, intravitreal medication that targets inflammation. Vabysmo is new on the market, and it targets inflammation as well as being an anti-VEGF. So it's a combination of both. And so that's a similarity. And how we investigate them, I'm sorry, I don't think I have a slide with showing the OCTA. Someone else may have it in a later talk. But investigations like fluorescein angiography and OCT angiography are very useful in diabetics. It's a matter of fact, it's indispensable in the treatment of diabetic retinopathy, and can be used to view the microvasculature around the optic nerve head. And the studies have shown also that a dropout of the small vessels around the optic nerve head is actually associated with the apoptosis and the optic neuropathy in glaucoma. So there are a lot of parallels, apart from the fact that diabetes, of long duration and being uncontrolled, can actually cause retinopathy that leads to a different type of glaucoma or neovascular glaucoma. So the chemical responsible for the whole cascade is actually the vascular endothelial growth factor, VEGF. And so this microangiopathy causes retinal ischemia, which leads to neovascularization on the disc, on the retina, and even in the angle, the drainage angle. That's the NVD, NVE, NVA. And this growth of new vessels in the angle, and when you do gonioscopy, we see blood in the angle, we see, if you can see the angle, you see the blood vessels going towards the angle, but oftentimes this angle is not even visible. The trabecular meshwork is obliterated by blood vessels, and it causes a secondary angle closure. And the secondary angle closure is what would cause Mr. X to come in with eye pain and eye pressure of 48 and blurred vision. So glaucoma that results from diabetic retinopathy, proliferative retinopathy, can actually stand on its own as a neovascular glaucoma, or it can overlay what was originally an open angle or a normal tension glaucoma. If it does that, then that's what we call a complex glaucoma. So glaucoma is just not necessarily open angle, narrow angle, normal tension, or low tension, but it can get complex by being a combination of some of these. So neovascular glaucoma, which is actually what we are basically aiming at when it comes on to diabetes aggravating a glaucoma situation, is a painful, blinding disease, and you have to act on that pretty quickly. It can be an acute, it can be chronic, or it can be acute and chronic. It's a dilemma in glaucoma management because it's damned if you do, damned if you don't kind of situation, because a lot of what faces you, they have to act fast, and you can't just jump in and lower the pressure by any means necessary, because you trigger high female trigger intraocular bleed, so it has to be done in a sequential manner. So first and foremost, the diabetes, Mr. X's diabetes has to be controlled. You know, you can't walk in with a 16.9 GMR. Sometimes the GMRs of 28. You know, these belong in a hospital bed, but they do walk into the office and with these complications. And we would really uh, love to co-manage with our family doctors to ensure that the hemoglobin A1Cs of these patients are where they should be, especially if they're for surgery. And of course, the hypertension needs to be controlled because that can affect how the situation progresses, because the amount of high fever, the amount of bleeding in the eye can be aggravated by uncontrolled hypertension. So our first we'll stay on the previous slide. Yes, so we have to reduce the intraocular pressure. That's very important. And we have to manage the inflammation, which is also very important. And manage the neovascularization and the high femur. So there's a lot on our plate when this walks into our office. Before we can apply laser, we have to be able to see what we're lasering. And so an eye with neovascular glaucoma, laser is not necessarily the first thing to do, because if you shoot the iris with a YAG laser, it will bleed and you'll get nowhere. And so what I tend to do, maybe this slide is pretty, yeah, okay, so let me start here. So the laser slides shall come after. It's an emergency, and so you can employ the use of oral Diamox, which is given to 500 milligrams as start dose. Mannitol is a very useful drug to give, but it's not very well readily available in Jamaica these days. But if it is, then that's a nice way of reducing the intraocular pressure in real time, so that one can inject 0.075 milliliters of Avastin, which is an anti-VEGF. Avastin, as you know, is traditionally used in it's colon cancer, something like that, but it actually is what we can afford. There are other alternatives, but let's use Avastin for now. You inject that and you get rid of those vessels within maybe 2 to 3 days. Normally, when I see the patients within a week, the vessels are all gone. So it's very, very effective. It works pretty fast when injecting intravitreally. And at the same time as injecting it, one can do a vitreous tap to, because we don't want to add volume to a 48 intraocular pressure. So that tap can be done at the same time as the injection of the Avastin, and then the patient comes back in a few days. I would say if I inject on a Monday, they come back, say, on a Thursday, and we can do a YAG PI. YAG PI is just using laser, the YAG laser to punch a hole in the iris, pretty much, which settles the angle closure aspect of things. And usually a combination of the Avastin and the YAG PI normally would get the patient to a comfortable level, along with, of course, the oral Diamox. Drops are of no use at this point. And although glycerol is of some use in narrow angle attacks, because it really brings the pressure down to the fact that it can send the patient's sugar through the roof, so you don't use the diabetics. Once the YAG laser is done and the openings in the iris, then one can proceed to do a pan-retinal photocoagulation laser, which is a more permanent solution to the retinal ischemia and the neovascular problem. If there is, I'll show you a slide soon, which if it's that stage of proliferative retinopathy, then surgery would definitely be on the cards. If vitrectomy would be on the cards. I have had to put a drainage tube in some of these patients, because sometimes the situation is stubborn, especially, as I said before, if it complicates previously existing glaucoma, then everything gets decompensated. Nothing responds as it should. And so if we can get the chamber to be deep enough, get the neovascularization to go away, but the pressures will not settle even with oral Diamox and adding some drops. Then we place an armored valve device, which one of our presenters has shown some photos of some of these devices. There is a new device that I've been implanting as well, called pressure flow. The pressure flow does carry a plate, and it is, I would add it to the range of mix, because it really, you know, 1 millimeter, or just barely more than a millimeter opening to put a tube in, and it's useful. It's quick. It's quite uncomplicated. So something like that may work. But of course, they maybe need to repeat the Avastin a few times until the laser burns show up and the retina settles. And of course, we can always employ the use of our topicals as appropriate, depending on how the case progresses. Yeah, so that was the photo I was talking about. That was taken with our camera, the confocal biomicroscopic camera. So it's really using laser images to reconstruct the fundus. I like it because it lends itself to good magnifications. And so as family practitioners, if you send patients for photos, it's best not to have printed photos sent to you. Just send your email address and you can get the image on email, and you can play around with it and you know, do the zooming and so on. And it's more useful that way than when it's printed. Okay, and so this is a photo of a, well, it's not Mr. X, but it's a similar case where you would have had all hell with a broken loose in the eye, and this is the valve tube, and you can see it kind of subconjunctival there, and usually the plate rests somewhere superior temporally under the conch that's on the upper lid. And so that usually does pretty well in draining the tube. Very rarely have to put 2 devices and so on, but most time 1 armored valve is enough to take care of the intraocular pressure. So I think that is about it. We can go back to our question in terms of Mr. X, and you know, we ask, so what is the cause of Mr. X vision dilemma? Is it his diabetes? Is it the worsening of his pre-existing glaucoma? Is it the new vessels that invaded his drainage angle, or is it all the above? And of course, it's all the above. And how do we treat, I'm just to answer the questions. Okay. Okay. You answer the chat. Okay, so I won't answer the questions. But yes, how do we treat this emergency? Do we remove the eye immediately? Do we give him some glycerol to drink? He's a diabetic, why not? Do we administer oral Diamox, IV mannitol, do an Avastin injection, follow up with laser? Or do we just drain the excess aqueous in the office? You can, as Dr. Badros says, just leave the answers in the chat. So, I guess there may be questions at the end. Those are my sources. And thank you very much for your attention. Okay. And to see.
Okay.
Yes.
Thank you so much, Dr. McIntosh. Our final presenter for the evening is also from the Deep Eye Center, and that is Dr. Gupta. So Dr. Divakar Gupta is a board-certified, fellowship-trained ophthalmologist specializing in medical and surgical treatment of glaucoma and cataracts. He performs both traditional glaucoma surgery, such as trabeculectomy and glaucoma tube shunts, as well as cutting-edge, minimally invasive glaucoma surgery. He is trained in the latest surgical techniques of cataract and laser-assisted cataract surgery. Dr. Gupta also offers premium intraocular lenses for cataract surgery patients interested in astigmatic correction and/or presbyopia correction. He has a clinical and research interest in early diagnosis of glaucoma and improving treatment outcomes. His research focuses on novel ways to use optic imaging and technology to identify and manage glaucoma. Dr. Gupta also spends time teaching and lecturing trainees and eye professionals at the Duke Eye Center and in the community. When he's not working, he spends his time watching Duke basketball, playing tennis, and he enjoys cooking. Dr. Gupta, I hand over to you. Thank you, sir.
Well, thank you, everybody. Can you hear me and see
Yes,
my
we're
screen?
hearing you. Yes.
Perfect. Well, thank you for inviting me to this talk. I'm a glaucoma specialist, and so I'm particularly interested in talking about glaucoma, and I'm thankful that you guys are taking this topic so seriously. You know, glaucoma is such a difficult disease to treat, but it's so important to diagnose it early so we can initiate treatment early. I've also included my email. Please email me with any questions related to this topic or anything. We'd love to interface with your group more. I have no relevant financial disclosures related to this talk. Well, I'm in North Carolina today. We do have palm trees here as well, but we had a lot of snow today. So while the other presenters that were from Durham, North Carolina, love to be interacting with you via Zoom, we wouldn't have minded to be there in person either. I had two questions that are related to this talk, and hopefully throughout the talk we'll get to the answers. My first question to the group is, which of the following are risk factors for glaucoma? A family history of glaucoma. B, increasing age. C, low corneal thickness or a thin cornea. Or D, all of the above. And my second question to the group is a true or false question. Is treatment of patients with ocular hypertension, did it result in reduction of glaucoma development compared to patients who were observed? Is that true or false? So we'll tackle those two questions throughout this talk and then go over them again at the end. So, you know, really what I'm talking about today, it has to do with ocular hypertension and glaucoma, but I wanted to remind everybody that there's many eye conditions out there. Dr. McIntosh just eloquently talked about diabetic retinopathy and changes related to diabetes that can affect a lot of individuals over the age of 60. And so, you know, in America, we recommend, according to our Academy of Ophthalmology, a screening eye exam by the age of 40. As there's more and more people and less ophthalmologists, screening is going to take on different components. It may not be interfacing with an eye care provider, but then sometimes getting screened via fundus photography or other photography that might be reviewed either by specialists or by AI programs in the future. And I think we'll hear some about that tomorrow. Now, if a patient has risk factors associated with glaucoma or really any condition, they may have to have more frequent or earlier examinations than the age of 40. I also wanted to pass along this website that you can interface with in your free time. This is the Glaucomatous Optic Neuropathy Evaluation Project, also known as the GON project. And you can Google this, but basically, if you sign up through this website, they'll present you with many images. These are images of optic nerves like we see here on the screen. And you have to grade these optic nerves based on different criteria: disc size, disc shape, tilt, something called the cup to disc ratio, cup shape, cup depth, and whether there's a presence of a hemorrhage or not. And the reason these signs and features are so important is because this is really how we make the diagnosis of glaucoma on a photograph. Is we look at an optic nerve that we think is susceptible to glaucoma, and we look for signs that tell us that a person's had previous damage that's most likely from glaucoma. So glaucoma has these characteristic optic nerve head findings. And if you can hone your skills, I think you could use a direct ophthalmoscope, or if you have access to pictures, you can look at pictures of the optic nerve and really diagnose a patient if they have glaucoma. So what is ocular hypertension? Well, you know, it's elevated eye pressure of the eye. And there's a couple different criteria that have to be fulfilled for someone to have ocular hypertension. One, they have to have a normal appearing optic nerve. And that means a couple of things: a low cup to disc ratio. What's a cup and what's a disc? Many of you may already know that already, but basically the disc has a certain diameter. And if we draw a vertical line through the disc from one end, the superior end to the inferior end, and then we see what proportion of that line is taken up by the cup. The cup is the hole in the middle of the disc that we think is just a potential space. And if that ratio is less than 0.3 or 30% or less than 0.5 or 50%, those tend to be lower cup to disc ratios, ones that we're less concerned about glaucoma. But if that ratio, that cup, is taking up a larger proportion of the disc, then we get more concerned of glaucoma. And so another way to think about it is everybody's optic nerve is sort of the shape of a bagel or a donut with a hole in the middle. And as we get damage from glaucoma, the hole in the middle grows because we're losing the rim of that donut or bagel. And so that's what glaucoma is. It's loss of the nerve tissue that makes up the rim of the optic nerve. Other things that we think make a more normal optic nerve is if we compare one optic nerve to the other. In glaucoma, there tends to be asymmetry, meaning one eye may have a greater cup to disc ratio than the other. If the two cups look more similar and have low cup to disc ratios, we're less concerned about glaucoma. Other features when we look at the optic nerve that could be symptomatic or signs of glaucoma are if there's sloping or notching of the nerve rim. If there's areas on the rim of the optic nerve that basically are focally lost, that would be consistent with glaucoma. Or if we see blood spots or hemorrhages. We think that hemorrhages represent areas of active damage where we're losing nerve fiber layer cells and the capillaries in that area may hemorrhage. Other criteria that are important to remember when we're diagnosing ocular hypertension is that a patient must have a normal visual field. A visual field is a test of a patient's peripheral vision. Dr. McIntosh showed some nice images of patients with mild and more severe cases of glaucoma. And glaucoma typically affects our peripheral vision before the central vision. And so we may use a screening visual field, or in the States, we commonly use a Humphrey visual field. That's just a machine that performs the visual field in a standardized fashion. And this is one way that we can screen or diagnose glaucoma. Finally, a patient must have an eye pressure greater than 21. The normal range of eye pressures is typically from 8 to 21, and that's where most people fit in. In ocular hypertension, patients have elevated eye pressure, and elevated eye pressure may be a risk factor for glaucoma, and it's the only modifiable risk factor, and that's why we pay so much more attention to eye pressure than other risk factors for glaucoma. Risk factors for ocular hypertension, aside from the three things here that make up the definition, are a family history, diabetes, long-term steroid use, a history of trauma, and then two conditions, one called pigment dispersion, another called pseudoexfoliation. These are conditions that particularly affect the eye, and both these conditions have one thing in common, is that they liberate pigment in the eye that clogs the drain of the eye, the trabecular meshwork, and that leads to elevated pressure. I wanted to contrast what we just talked about with ocular hypertension by what are the definitions of glaucoma. And commonly, I'm talking about the most common form of glaucoma, primary open-angle glaucoma. So primary open-angle glaucoma is a chronic, progressive ocular disease that causes the optic nerve rim to be lost and the retinal nerve fiber layer to be affected, and it's associated with visual field defects. That's why when we talked about ocular hypertension, we were really talking about a normal optic nerve with no visual field defects. My former chair here at Duke used to say that it's a diagnosis of exclusion, and this is very true. Dr. McIntosh just showed several examples of other types of mechanisms that can cause glaucoma that would not necessarily be primary open-angle glaucoma. So we have to think about other causes before we settle on the diagnosis of primary open-angle glaucoma. And for the purpose of this talk, I'm not distinguishing normal tension glaucoma and as a different type of primary open-angle glaucoma, but just know that even at normal pressures, patients can develop glaucoma. I had the good fortune to write a review in the American Academy of Family Physicians Target Journal, and you can look this up. It was published in 2016, and it provides a nice review of glaucoma. And there we reviewed the risk factors of glaucoma. And the two risk factors that I think are particularly important to remember are that family history of glaucoma is a risk factor that puts people at high risk for developing glaucoma, and increasing age is also a risk factor. So those are two quick things that you can screen a patient as to their risk for glaucoma just in the clinic without even doing an eye exam. And you can either recommend earlier eye examinations to patients at high risk or perform other detailed tests in your clinic to see what their likelihood of having glaucoma are. So how do we distinguish between ocular hypertension, or OHTN, and glaucoma? Well, one is we need a structural test. So we need to look at the optic nerve. That can be done by direct ophthalmoscope, where we're looking at a very magnified view of the optic nerve. We're looking at the cup to disc ratio. We're looking to see if the rim has notching or sloping, and we're looking for hemorrhages. We also, if we have access to them, we'll do fundus photography. And then we saw some examples of optical coherence tomography, which is really, I think, a better tool because we can get far more information from an image that usually patients can tolerate better in terms of their ability to sit still while the image is being acquired. We also need a functional test. This means a visual field or something that gets at a patient's peripheral vision to see if they have any blind spots. And it's important to remember that open-angle glaucoma tends to be bilateral but asymmetric. I just wanted to show you another example of an OCT. This is the machine platform that we have here at Duke, which is made by a company called Heidelberg. But basically, it takes a very detailed picture of the optic nerve, and it measures the top layer of the retina, which is called the retinal nerve fiber layer. That's what makes up the optic nerve. We look at the thickness of the tissue in that layer, and in glaucoma, that layer gets thinner over time. So we can use this for diagnosis if a patient's retinal nerve fiber layer is thinner than the average in our population, or we can also use this machine for progression because we can compare an individual to themselves. And in glaucoma, like I said, the nerve fiber layer gets thinner over time. We also use visual fields. Visual fields test what we usually just a little more than just the center part of the vision. They get at some of the periphery of the vision. And if we see defects in those regions, we could be concerned that this patient may be developing glaucoma. And if a patient has very, very extremely signs of glaucoma in one eye and not the other, we think of other causes than primary open-angle glaucoma. I've just listed some here. Dr. McIntosh went over some, but just know there's other types of glaucoma that we should be concerned about. But the most common typically is primary open-angle glaucoma. And these are just some examples of pigment dispersion or pseudoexfoliation. These are great photographs that have been zoomed in on the eye. And you can look these up. And sometimes you can even diagnose these in the clinic with a pen light or a smartphone camera. The technology is becoming better and better. So I think that primary care physicians will see some of these findings even in their clinics more and more. So what about treatment of ocular hypertension and glaucoma? A large amount of how we treat ocular hypertension was based on this study that was started in the late 90s and actually just completed 20 years worth of data recently, and it was published. This is called the Ocular Hypertension Treatment Study. And basically what this study did is it looked at patients that had elevated pressure in one eye between 24 and 32, which is outside of our normal range, had also elevated pressure in the other eye, and that had a relatively normal exam, normal optic nerve, normal visual field. and it followed those patients over time. They randomized some patients to treatment and with an eye drop to lower their pressure, and others to observation. And what they found after the first 5 years is that 4.4% of the patients in the medication group, the group that had their eye pressure lowered by medication, still went on to develop glaucoma. Whereas in the group that they observed and did not treat, 9.5% of them went on to develop glaucoma. So one of the conclusions from this paper, at least at the 5-year mark, was that if we treated 20 people, we could prevent 1 glaucoma. And so this is one reason that a lot of us do treat patients with ocular hypertension, is because we think that the treatment is pretty benign. It's an eye drop, and if a patient's able to take it, we can decrease their risk of developing glaucoma by about 5%. And if we treat 20 people, we can save 1 person from developing glaucoma. There's one other key finding from this study, and it's this a graph that's on the right. And what this graph showed is of the patients that were in the observation group that did not receive treatment, they stratified patients based on the thickness of the cornea and also based on how big the cup to disc ratio was. So what they showed, it's a busy graph, but what they really showed is patients that had a very thick cornea, that's in the bottom right of the screen, and a low cup to disc ratio, had a very, very low chance of developing glaucoma. Whereas patients that had a thinner cornea and that had a higher cup to disc ratio in the upper left of this graph were at much higher risk to develop glaucoma. So, there's a lot of reasons why this is. A patient with a low cup to disc ratio is somebody who probably doesn't have glaucoma or hasn't shown damage because they still have a lot of their optic nerve rim. So that makes sense. But this novel discovery of the thickness of the cornea was interesting. We know that the thickness of the cornea, when a cornea is very thick, when we sample someone's eye pressure, we're probably over measuring it. So if we sample a pressure of a patient with a very thick cornea and we get 25, their pressure is actually lower than that. And the inverse is true for patients with thin corneas. If we take a measurement of a patient with a thin cornea, it's likely the actual eye pressure is higher than what we measured. And that's one reason, and there's some other reasons as well, but basically patients with thicker corneas tend to develop glaucoma at a lower rate, and their eye pressures are likely lower than what we're measuring. So because of this study, there is this risk calculator that you can download online. It's a PDF file that you can have on your desktop. And when a patient comes in, by a couple of criteria, you can determine what their risk of developing glaucoma over the next several years are. There are some data that you need. You need the age of the patient. You need the eye pressure. You need the thickness of the cornea, which can be measured by a specific instrument that ophthalmologists and optometrists have access to. And you need to know what the disc looks like and the patient's visual field. But if you have this information, you can stratify patients. And this is how I can stratify patients in my own clinic and determine if we need to treat them or not. And patients that have a less than 4% risk of developing glaucoma, usually we don't necessarily need to treat. So what are the treatments for ocular hypertension? We had some presentations on that earlier. Well, one treatment is observation. A patient with thick corneas or a low cup to disc ratio is less likely to progress. And if you have good follow-up for that patient, you can observe them with serial exams. Another treatment is to stop any offending agent that could be causing elevated eye pressure. So this could be stopping steroid medications, because steroid medications very likely would raise someone's eye pressure, particularly when they're taken for long term. It's steroids that are closest to the eye that tend to be most impactful. So topical drops of steroids, creams of steroids around the eye that tend to raise eye pressure. But oral steroids or even steroid injections can also raise someone's eye pressure. Another treatment for ocular hypertension, if the patient's risk is great for developing glaucoma in the future, are the medications that you've heard about earlier, or selective laser trabeculoplasty, which you also heard about in an earlier presentation. It's important to remember that this laser, SLT, or selective laser trabeculoplasty, is not curative. It is repeatable, as its effects can wear off over time, and it may be equivalent to starting an eye drop. It may be preferred because it takes a patient adherence out of the question. What are the treatments for glaucoma? Well, they're similar, but they depend somewhat on our classification. Typically, we treat glaucoma, but there are cases, like in the elderly, in patients that are at low risk for progression, that we can observe without treatment. If we're talking about open-angle glaucoma, either primary or secondary, we usually start with medications. Laser may be effective in early treatment. And then some patients need to go on to having surgery, particularly if they're poorly managed with medication or laser, if they can't take medications, or if they continue to progress despite being on medications or having laser, then we may consider treatment with surgery. This can be minimally invasive glaucoma surgeries or more traditional surgeries such as trabeculectomy or placing a tube in the eye. All these surgeries can be very effective, but typically in more advanced disease, we prefer trabeculectomies and tubes because they're more likely to get the eye pressure lower. Those surgeries also carry greater risk. In patients with a closed angle mechanism, we may add to this algorithm cataract surgery, because cataract surgery may be instrumental in lowering someone's eye pressure. It may be paired with glaucoma procedures to lower someone's pressure. And it can be done in lieu of medications or laser, because the mechanism in closed angle is that the aqueous humor doesn't have access to the angle of the eye, which is where the drain is, where the trabecular meshwork is. And so by opening up that angle with cataract surgery, we may be able to reverse some of the mechanism that causes glaucoma in those patients. And this is just a reminder to drive home that point, that in some patients, cataract surgery can be really effective at lowering the pressure. In open-angle glaucoma, before and after cataract surgery, which we call phaco, there's a slight decline in eye pressure. But in patients with angle closure glaucoma, the bars that you see on the right, it's quite dramatic, the amount of eye pressure lowering we can get with cataract surgery, almost 6 millimeters of mercury, which could place somebody from almost the outside of the normal range and get them back into the normal range, and basically decrease their risk of ongoing progression from glaucoma. So I just want to summarize the things that we talked about. Ocular hypertension is defined by a normal optic nerve and a normal visual field. So a normal structure of the eye, normal function of the eye, and elevated eye pressure. The treatment of optic nerve that should be ocular hypertension reduces progression of glaucoma, and treatment can be with medications or laser. But there are a small population of patients that we can observe, those with thick corneas and those with low cup-to-disc ratios. Risk factors for glaucoma include family history, age, a thin cornea, and elevated eye pressure, and increased cup-to-disc ratio. And patients should have a screening eye exam of some point at age of 40. That gives us the opportunity to intervene at earlier steps and early stages of glaucoma, rather than advanced stages where our treatments may not have as much impact and can potentially be a little bit more dangerous. So thank you so much for your attention. I'll go over those questions. Which are the following risk factors for glaucoma? Family history, increasing age, or lower corneal thickness? The answer is all of the above are risk factors for glaucoma. And question 2, the treatment of patients with ocular hypertension result in reduction of glaucoma development compared to patients who are observed. Is this true or false? And this is actually true. I highlighted the wrong one, but it's actually true that it reduced the development of glaucoma. So thank you so much for your attention, and I'm happy to answer any questions.
Great. Thank you very much, Dr. Gupta. So we're into the question and answer segment of our seminar. Questions can be placed in the Q&A box to the bottom of your screen. And let me go, so I'm inviting all our panelists back to the stage. So the first question here that I see by Tracy Lumley, is there any ongoing research on the benefits of cannabis in treating glaucoma? Anyone can take.
Figured that question would come up, but not to my knowledge. The experience I had with the cannabis drop, was that it did do something to help with the optic nerve head perfusion. And it wasn't, I don't think it was so much a competitor for those IOP lowering drops, but it was more of an adjunct therapy. But unfortunately, since that patent went out, I don't think anyone has taken it on, not to my knowledge. So we have the unfortunate situations where patients are boiling all kind of cannabis concoctions and dropping it in the air and turning up with all kind of conjunctivitis and so on. So no, I am not aware of any further research. I don't know if anyone else is.
No, I agree. I mean, cannabis, when inhaled, can lower the eye pressure, but its duration of action is so short that it wouldn't be practical for cannabis to be used in the treatment of glaucoma. You know, our treatments by eye drops, some of those eye drops last 24 hours. You know, the most common one, the prostaglandin analogs, one drop can last 24 hours. And so those are going to be much more long lasting and preferred treatments for glaucoma.
Thank you, both Dr. Gupta and Dr. McIntosh. Another question. In patients with normal intraocular pressure and corneal thickness with a family history of glaucoma and exhibiting a larger optic disc, how do you recommend the management? The person.
Sorry, I missed that question. Could you say it one more time?
Sure.
I think you're coming a little bit low, Doc. Hold on. Let me see if I can help. So in patients with normal IOP and corneal thickness with a family history of glaucoma and exhibiting a larger optic disc, how do you recommend management?
Okay, so one thing we should be careful to note is that the saying goes larger nerves will show larger cups, smaller discs will show smaller cups. So not every large cup means glaucoma. And so I would still go back to using the OCT and the visual fields as a guideline, and as to whether or not we observe or we go ahead and treat. So we certainly investigate, and with the aid of these investigations, then certainly go ahead and treat. You don't want to wait too long. The family history, certainly, I find in my practice a very important one to note, and it would not hurt to at least do some neuroprotection using a drop that will afford you some lowering of intraocular pressure and some protection of the eye nerve, optic nerve.
I completely agree with Dr. McIntosh. So this patient sounds to be a high risk glaucoma suspect, and his point is well taken that patients that have a big disc may have a big cup that will not be pathologic, whereas patients that have a small disc may have a normal appearing cup to disc ratio, but it could be pathologic, meaning that they could have glaucoma. So following a patient like this over time to see if there's progression of disease by the OCT, screening them with a visual field machine to make sure they do not have a visual field defect would be paramount to make the diagnosis of a glaucoma. But at this point, with the information provided, the patient would be a high risk suspect.
There's a question in the chat that says, what percentage of the population over the age of 60 has glaucoma?
That's a hard one because I don't think we have any data like that in Jamaica. But I could say I'd always tell persons that I run a busy ophthalmology practice, and safely, I could say 40% of my practice is glaucoma. It's a very, very high population in our certainly not in the Caribbean. But I cannot speak to whether or not it's 10% of the population over 60. I know that there's a lot of undiagnosed glaucoma because normal tension or low tension glaucoma is actually very common. And it is the commonest cause of permanent blind, of irreversible blindness then in the Caribbean. Glaucoma is ahead of diabetes.
Yeah, here in the States, sometimes we quote about 4% above 60, but then it goes up by every decade of life. So when we're looking at like 80-year-olds, it could be up to 8%. It's quite common, but I wouldn't be surprised if it was higher in the Caribbean.
Thank you so much. Go ahead, Dr. Booker.
Okay, we also have another question here. How often do you recommend screening with OCT?
Okay, so in an ideal world, an annual OCT is recommended, but I tell my patients at least every 2 years. But it actually should be annual. But of course, there's a cost factor that's involved, whether or not insurance will cover it. I think that the NHF should step in and do something about it, at least make some allowance for periodic OCTs and visual field as a part of their offerings to the patients.
What are the adverse effects of Rocklanda eye drops, and why is lantoprost contraindicated in patients with macular edema?
Repeat the first part of the question.
What are the adverse effects of Rocklanda eye drops? ROCLANDA.
I think are you referring to Rocklatan? Yeah. There's a medication called Rocklatan here in the States. It is the urokinase inhibitor with latanoprost together. So the urokinase inhibitors, the main medication that we have here in the States is Tarsadil, that goes under the brand name of Ropressa. It has some side effects. Some are just because of the mechanism of action that Dr. McIntosh highlighted in his presentation, that it causes relaxation of some smooth muscles, and so it causes some of the vessels on the surface of the eye to be more dilated, so there can be some hyperemia related to Rocklatan. It also causes something called corneal verticillata, which is some spoking on the surface of the cornea, and generally can be a little bit irritating to patients, and so some patients have difficulty continuing on that drop. The second part of the question was, why is latanoprost contraindicated in patients with macular edema? There's a thought that latanoprost, which is in a class of medicines called prostaglandin analogs, are pro-inflammatory. And so in patients that have macular edema, usually the reason they have the edema is because of some inflammation or a pathway that's similar to some inflammatory pathways. And so if you're taking a medication that's potentially pro-inflammatory, we're worried it could make it worse for people that are predisposed to having macular edema. Although there's some new literature that's put some question whether that's true or not, but that's typically why we avoid prostaglandin in patients with macular edema.
Thank you so much, Dr. Gupta and Dr. McIntosh. I see two more. What advice would you give for an older person who has difficulty with the glare from oncoming vehicles at night and who has borderline glaucoma and an early cataract?
First signs of cataract development, and so the notion that one should wait until the cataract is ripe already. I mean, patients are told that by the doctors sometimes. We want to dispel that myth. The cataract should be done early, because if they have glaucoma as was presented earlier by Dr. Gupta, it's best to remove that cataract to create more space for aqueous to drain. So cataract surgery, an early cataract surgery or lens exchange surgery is actually a treatment on the treatment card for glaucoma, because you're putting a thin implant in place of a thicker lens, because cataract usually sometimes involve not only an opacification but an enlargement of the actual crystalline lens.
Thank you so much, Dr. McIntosh. Dr. Gupta, you had wanted to add something.
Oh, I totally agree. Both conditions, glaucoma and cataract, affect contrast. And so, a patient that's having more difficulty in dim lighting situations, such as night driving, if they're getting glare, and their driving's impaired, then it's important to improve contrast. And we can't really reverse glaucoma, but we can reverse some of the effects on contrast from the cataract. So having cataract surgery should hopefully improve someone's contrast and hopefully, in this case, decrease glare at night.
Okay, thank you so much. Our second to last question for the evening. What ocular drops do you recommend and frequency of dosing for use of prophylactic large optic disc, positive family history individual? So let me say that again. What ocular drops do you recommend and frequency of use for prophylactic large optic disc and positive family history individual?
Because I don't usually lay the diagnosis of glaucoma in a patient unless I can prove it, with investigation. Not because you have a large optic disc, as we said earlier, means you have glaucoma, but you have to look at the angle anatomy, whether or not there may be intermission, closure, etc., etc. You look at the intraocular pressure history and so on, and make a determination. And of course, we mentioned earlier that an SLT, for example, if the pressures are borderline, an SLT would be decent enough prophylaxis, unless you want to think of how you could actually help the patient with some more neuroprotection if the pressure is normal, which I think we'll get into some of that in tomorrow's presentations, because there are some dietary options and other practical options, like a sleeping position and so on, that can help with improving ocular blood flow to the optic nerve and be better prophylaxis than those drops. I wouldn't jump to drops. There are other methods that can be employed.
Okay, all right. Thank you so much. So we'd like
I
to
think the
thank all.
final
Yes, ma'am.
question, Doc, is in the chat, and it is: are there any eye
Oh.
drops for glaucoma that increases the risk for cataracts? So the question is, are there any eye drops for glaucoma that increase risk of cataract formation?
So, all the eye drops carry some risk for accelerating cataract, but it's usually pretty minimal. Anything that we put on the ocular surface technically can increase the risk, but yeah, all the eye drops in the studies have shown to be slightly cataractogenic, but typically it's pretty minimal. Remember, a lot of times we're treating patients that are above the age of 60, so it tends to be a group that is already noticing their cataract more and more. So it may not be very quickly progressive in terms of how much cataract is changing from an eye drop, but those patients are likely to get cataract surgery anyways.
Great, thank you so much, Dr. Gupta. And this brings us to the end of our seminar for tonight. I'm just gonna ask Dr. Dean to make closing remarks, and thank you all. Go ahead, Dr.
A pleasant good evening to one and all, to my colleagues and to our presenters. It is my pleasure indeed to move this vote of thanks on behalf of our president, Dr. Seni Ananuju, our executive and our members at large. It has been an extremely informative and interesting group of presentations this evening on our topic, Clarity in Sight, Advanced in Eye Health and Glaucoma Management. And this, I must say, has been well received. Excellent presentations overall. But let me begin by thanking our moderator, Dr. Kian Bukal, for an efficient and excellent job in guiding us through this seminar this evening. And also Dr. Arna Brown Morgan, family physician and executive board member of this Caribbean College of Family Physicians Jamaican chapter, who did the opening prayer, and Dr. Seni Ananuju, our president. She did the greetings and welcome and led us into the beginning of the seminar. Dr. Maynard McIntosh and Dr. Renee Badreau did the first presentation on silent thief of sight, understanding risk factors, early detection and management strategies in glaucoma. And they actually ended up doing 2 presentations. So just to recognize their tremendous input in this seminar and to say thank you to both of them. Also, Dr. Liu, consultant ophthalmologist who did the pediatric aspect of glaucoma, early detection and management strategies, understanding congenital and juvenile glaucoma. Rather interesting and informative, all the new developments that we're exposed to. Advances in medical and surgical treatments for glaucoma, exploring the latest therapies, including minimally invasive glaucoma surgery, was done by Dr. Nathaniel Letcher, consultant ophthalmologist, and he was followed by Dr. McIntosh and Dr. Badreau, again, who did diabetic eye disease and glaucoma, the dual threat, the impact of diabetes on glaucoma progression and management. Finally, to round it all off, Dr. Gupta did the ocular hypertension versus glaucoma and gave us insights as to when to start treatment, clinical decision-making for primary care physicians and ophthalmologists. So thank you all, lady and gentlemen presenters. All presentations were excellently done, were well received, were very informative, very interesting, and I'm sure I share this, as did all the participants, all 229, which was the high point of the participation this evening. I would also like to say thanks to our sponsors, Indus Life Sciences, who so graciously sponsored this webinar, this seminar webinar this evening. Allgate Solutions, headed by Sam Heron, for their technical support, efficient technical support once more. And of course, our administrator, Mrs. Lynn Thompson Hyatt, and her administrative team, who together with Dr. Seni Ananuju and the other executive members of the Caribbean College of Family Physicians Jamaican chapter, were responsible for the organization of this webinar, which was so well received. I must also thank our participants, who I'm sure all benefited and enjoyed this presentation and have learned a lot. I speak for myself also, and saying that I learned a lot from all of these well-informed and wonderful presentations. And just to note that our presenters were local and international presenters, a blend of excellence this evening. And just to say thanks once again to you all, and we look forward to tomorrow's, the second half of this, of the 2 evenings, tomorrow's presentation, which will be again on ophthalmology topics. So thanks once again. God bless you all. Have a wonderful evening, and we look forward to tomorrow's presentations. Thank you once more.
And thank you, Dr. Levy. Thanks to everyone. Thank you, Dr. Bukal. Have a wonderful evening and see you tomorrow, 7 p.m. again, for another series of wonderful talks on ophthalmology. Have a wonderful evening, everybody. Cheers.
Thanks, cheers to you too.